All right. Thank you both. I know Olivia is going to start moving everybody over so they can ask questions aloud. I am grateful to both of you for fabulous presentations. I want to point out the value of FAIR, that Dr. Heifets was supported by FAIR, and that helped him get his NIH grant. And then something that you should know about Dr. Barker, all of that technology development work did not go for naught. He is, in fact, the top individual donor to FAIR. So I think all of you should thank him for his contributions. I still don't have any questions yet. I really hope there are some, because I have a lot of questions, but it's not my job to be always asking questions. Maybe I'll start with what advice will you give to the students that are here? Boris, I was interested that you said you didn't recommend a 3-year fellowship. I would say to people, I think investing in a fellowship that's long pays dividends, that if you had tried to make a shorter fellowship, you wouldn't have seen that big peak in publications. I recognize that there is a trade-off in income, so that is certainly a reason that you might not want to be a fellow forever, but maybe you could expand on, and Dr. Barker, I'd be interested in your thoughts as well on what is the value of investing time in training. Yeah, because Dr. Barker, you did 1,000,000 years of PhD, and Dr. Heifets, you did PhD as well, of training so that you've got a background before you jump into your faculty role.
Stephen, I'll start, and I'd love to hear what you have to say as well. Just a couple of comments. So I had, 3 years of fellowship, I should just point out, was on top of 9-year MD PhD. And plenty. So it's my point really is, not everybody has to be everything. So I'm kind of a little bit of a glutton for punishment, in that I couldn't envision a life where I wasn't doing both basic science and clinical research. And it's I feel like I'm very lucky to have made it out the other end. It's not really I think my advice, for example, for my own mentees is usually to focus on a more circumscribed goal. So, for example, if you didn't, without a basic science PhD, it's very difficult, for example, to catch up and make that the focus of a lab after residency. So, for example, like getting really good at statistics, doing a master's in epidemiology, like those are really great investments in time. And, obviously put in the time that you spend early on in your career does definitely pay dividends later. But yeah, so I guess my main message is, I agree with Dr. Hopf completely that, it is very worthwhile, that fellowship time. I wouldn't necessarily recommend doing that much fellowship for people who aren't set on the same kinds of goals that I set out on.
So I wouldn't necessarily recommend to anybody that you do what I did, although a number of people come into medicine from other careers, and my previous life has obviously had a lot of influence on what I'm interested in and what I do. But as Boris said, the important thing is, once you come up with an idea, a concept of something you're interested in, find a mentor, someone who's got some background in that area, and some relationship maybe with industry or background in funding their research. Let me tell you just a few words about why I ended up in anesthesia, because when I went to medical school, as a separate second career, I was 100% sure what I was going to be. I was an experimentalist in engineering. I worked with my hands. I built experiments. So I was going to be a surgeon, absolutely no question. And I actually started my residency in surgery back in San Diego, my hometown. And I completed a full year of surgery residency internship. And it was during that first year that I was looking over the other side of the drapes in the operating room, realizing that it was the anesthesiologists who were having all of the, what I considered fun, working with all the, not only the gadgets, but the physiology. And it was human physiology that really attracted me into medicine. So I switched after my first year. I guess the moral of that story is keep an open mind when you select your specialty. Anesthesia is a great specialty for people who are interested in doing this kind of research. I mean, look at just Boris and me as examples. Our research is very different from one another, and yet it is related. I could think of ways that we could actually work together. Anything involving, as I said, human physiology, devices, both treatment devices and especially monitoring devices, which is where I have focused in my second career. That's all within anesthesiology, and there's a lot of good mentoring help available in our field. People like John Severinghouse, as I mentioned, he has mentored literally hundreds of people, and he and I work together on a number of projects. I could give you a list of probably 50 people who could provide that resource in any given area that you want to select. And I think Boris and I are a good representation, a good cross-section, because like I said, anesthesia research is in two categories mostly. It's either drugs or it's technology, and you know the two overlap. And I promise you, if you go into anesthesia with a goal of doing research, you will find plenty of opportunities and plenty of people to help you with that. I'll stop there.
Thank you both. I think that's great advice. Elena Haight says she's in a loud room, so she doesn't want to read her question out loud. She's wondering if you can talk about the value of protected research time during residency. And specifically, it's aimed at Dr. Heifets, although I think Dr. Barker would be able to answer this as well. And because you're at Stanford, the value of pharm in providing protective research time in your early career. And we had Dr. Topham on earlier, so she talked about pharm. So hopefully our students remember what that is, but you might want to explain that too.
Yeah, so nice to hear from you, Elena. Elena was a student in Dr. Topham's lab and had a great time at Stanford. So pharm is our research residency. So I put a link on one of my last slides about ESAS, which again I'll plug. It's esashq.com. This is the Early Stage Anesthesia Scholars group. The thing I mentioned in my post was actually specifically about that is how do you look for a residency that's going to support you in doing research. So all of the stuff that Dr. Barker and I have talked about really requires quite a bit of training beyond what you're going to get in medical school. And I think the American Board of Anesthesia has done a wonderful thing in giving programs the option to devote a significant amount of time to research. So I think the standard ABA allowance is 6 months of research time during the 3 years of anesthesia residency. You can apply for an additional 3 months. So I did 9 months of research in 3 years of residency. So again, there are a lot of qualifiers to doing that and not and still being clinically well trained. So I just speaking just for what our process is at Stanford, we're really we don't select people primarily on their research skills. It's really on their clinical their clinical credentials. When we're looking at prospective residents, we also interview people for our research track, that's the pharm program. It's not a separate match number. And again, we're primarily looking for people who are going to be solid clinicians. And, it's always a plus if they have research interests, we want to be able to foster them. And that's what I encourage you really to look for is, if you're evaluating a program and you know that you want research to be a major component of your career, The things that you need to look at first are, has anyone done what you want to do at the program where you're going? If they've done it before, odds are they can do it again. If they haven't, it really requires a lot of infrastructure, and I didn't know what I didn't know starting residency, but all of the protected time means not getting pulled off of research to do a liver call. Obviously, I pitch in when needed, but really keeping that as time to develop your work and developing the network of mentors within the department. So those are really, I'd say, the two key things is making sure that other people have done done the kind of research track that you envision for yourself, and finding mentors that are interested in you and willing to take you on. And mentorship is probably the single biggest factor, I think, besides the department in success for people going down this road.
So I would, I second everything Boris said, and the only thing I'll add is when you're shopping around for a residency program, and as I already said, anesthesia is a great medical specialty to do research of all kinds. In the departments that you visit and get to know, look carefully at the faculty. How much time do they get for research? Do they get protected non-clinical time? What are their interests? Do they coincide at all with yours? And look at the papers they produce. What is their output? I can tell you, especially today, there are quite a few anesthesia departments where the faculty are getting way less non-clinical protected time than they used to. And that's sad, and I hope it's just a phase we're going through and it will change. So you need to look carefully at the departments. When I moved to Arizona in '95, I took over a department that had a relatively small number of faculty, and nobody at that time had protected non-clinical time. If the faculty don't have non-clinical time and encouraged to do research, it's going to be very difficult for you as a resident. You're going to have to be kind of self-propelled. I changed that. That's one thing I am proud of. I actually eventually tripled the number of faculty. I instituted protected non-clinical time every week for every faculty. And then in their annual evaluation, they had to tell me, hey, here's what I did with that non-clinical time. So it's the relationship with the faculty that's going to be key to you in starting a research career. And you need to get to know those faculty and what they're doing and whether their interests coincide at all with yours. That's it.
Okay, we have a question from Amanda.
Hi there. I'm Amanda Schaefer. I'm a second year at the Medical College of Georgia. And this is more directed towards Dr. Barker, but what was your path to gaining a leadership position in a biotech company? And in this role, how is your time split between clinical work and research? And then do you think that additional advanced degrees are needed or required to be a physician in industry?
Okay, let me start with the last question because that's easy. Additional advanced degrees are not required. I know a number of people who have great relationships with industry who don't have advanced degrees. They just kind of developed the research know-how as they went along. How did I become? The quick answer is it just sort of happened. When I went into medicine, obviously I was going to be involved in research that was somehow related to my first career in aerospace engineering. And so that took me into the device side. As I said, I consulted with about 15 different companies. The leadership role actually started in 1990, and I showed my disclosure slide, so it's no secret that I'm connected with Massimo now. In 1990, I was at UC Irvine. I hadn't become the chair yet. Two guys came into my office to show me a new product that they had invented, and it turned out it was Mohammed Diab and Joe Kiani, the two founders of Massimo. And I looked at their product and I thought, wow, it was an interesting idea. Let's try it. And we tried it, and one thing led to it. So my point is, I was involved with that company literally from the ground floor, when it literally consisted of two people, and the company was in Joe Kiani's garage. Now, as you know, Massimo is, it's the leading company in pulse oximetry manufacturer in the world, if you ask me, and lots of other products. So I guess the short answer is, getting involved in a startup company at the ground floor level is certainly one way to evolve into a leadership role, because you're there, you helped build it, and you know everything about the history. You learn from your mistakes. And the last thing I'll say on this is, level one of wisdom that I try to teach is learn from your mistakes. Don't make the same mistakes over again. Level two of wisdom is a much higher level, and that is, you learn from my mistakes, and I'll teach you. I've got a lot of time to do it, and so I've made a heck of a lot more mistakes than any of you have, and I can teach you to avoid those. So I guess that, evolving into the leadership role, it just kind of happens, especially if you're involved at the ground floor of a new company.
Thank you.
Mm-hmm. Surely someone has a question. It doesn't necessarily have to be about opioid receptors and ketamine. It could be about career development. It could be about technology development. Guys are making me work. It's not fair. Early in the morning. Krupa has a question. Thank you.
So I'm going to read this one out loud. I just
wait. So it's Krupa on somewhere?
Hi. Yes.
Oh, there we go.
Okay. Well, hi. Thank you guys for your presentation. So a few weeks ago for Journal Club, we did an article on correlations between general versus regional anesthesia, and how one of them could potentially have a higher correlation with postpartum depression. And I was just wondering if you had thoughts on that, or if you've seen any correlations between mental health disorders and anesthesia in other surgeries other than obstetric.
So it's a great question, and my first thought is, nobody knows. That's all. This stuff is relatively new focus. There's been a lot of work showing that depression is a risk factor for various bad outcomes. There's almost nothing, like, we don't even really know the natural history of depression around surgery. I mean, we know that bypass, for example, cardiac surgery is associated with higher rates of post-op depression. Most of the work in this area, you probably may have heard about, is around delirium and post-operative cognitive disorder, which there's a little bit of a controversial opinion. People have tried really hard to make that a real thing, and there's some interesting editorials out there. That why don't we talk about post-operative cognitive improvement, which also happens in some cases. But I think to answer your question, we don't really, we haven't measured any of this stuff. And I think that's, largely driven by what we can fix. And I think Dr. Barker could probably speak better on this, but, the kind of development of anesthesia, for over the last few decades, to me, looks like the better we can take care of patients, our anesthetic care, our ability to take care of very sick patients has enabled more and more surgery. And what are the kinds of things we can control? Well, hemodynamics, pulmonary physiology, better vents, less arrhythmias with modern anesthetics. So again, we focus on things we can control, and mood is really not one of those things, and hasn't been. historically, and certainly not in this space. So that's kind of, I think, the leading edge of perioperative medicine for me at this point.
I would like to add one thought, and that was excellent. Boris and I think alike, and we have never met before, I swear. One of the new groups in anesthesia, which is part of the ASA, is called the Perioperative Brain Health Initiative. And it's looking into the incidence of basically mental deterioration in various forms after surgery. And I can tell you some horror stories if we have time another time. But basically, this gets into my gadget side. There are papers, we know that a lot of, especially elderly people, have post-op, what we call post-op delirium. It may not be like agitated climbing the walls. It can be a silent delirium. We know that that delirium is now statistically related to post-operative cognitive dysfunction, which is longer term. And we know also that this cognitive dysfunction is related and predictive of long-term cognitive decline. So how do we stop that? It's a major problem. And like I said, I've heard some real horror stories, and I've seen some myself. Well, one thing we've already discovered is if we're actually monitoring the electroencephalogram with electrodes on the brain during anesthesia and surgery, there are periods of EEG silence. We call that burst suppression. And so there's new papers just within the last year or so coming out showing that if you have longer periods of EEG silence, longer periods of burst suppression, more than about 5%, that is predictive of postoperative cognitive dysfunction, which, as I said, is predictive of cognitive decline. So now we got a gadget that can help us, you know, if you're just very careful and don't get the patient too deep, maybe we can avoid a lot of these cognitive decline cases. And the last thing I'll say is, by the way, that's another way that doing anesthesia in the operating room is a lot like flying an airplane. I think subconsciously that's one of the things that attracted me to the field. You are a pilot of an airplane. The main difference is there's only one passenger in the plane, and that's your patient. But it's very interesting analogy. Thanks.
So I understand Dr. Barker has to leave right at 10. So I want to take this moment to thank everybody. And we do have some more questions, so I will get Dr. Barker's last question, but I want to, before it's actually the end of time, thank everybody. Remind you that on Monday from 4 to 5 p.m. Eastern time is another Obstetrics Journal Club. And on Wednesday at 11 to 12 Eastern time, we have a conversation about clinical and translational research. Dr. Barker, Benson has a question for you if you have 1 minute to answer it.
Of course.
Hi, Dr. Barker. Thank you for your presentation. So really quickly, if most of us do not share the same background in engineering and devices that you have, are there any other roles for anesthesiologists in industry-related consulting? And if so, what may those roles be, and how do you get into it?
Well, as I said, you don't have to be have a career in engineering to get involved in the engineering side even. So don't take my model as some kind of a requirement. It's just what happened. You know, life is very interesting. As you turn the pages, things happen that you didn't really anticipate. I don't regret any of my decisions about career, but it's been an interesting pathway. You can get involved in the engineering side of anesthesia very easily and very deeply without having a technical or educational background in engineering. If you're, smart people do very well. John Severinghouse, the example I used, he doesn't have any particular background in engineering. Kevin Tremper, who I used as an example because I worked with him. He's the one who hired me at UC Irvine. He has a PhD, but it's in chemical engineering, so pretty far from the gadget field, and yet he got into gadgets and did very well. So don't worry about not having an engineering training background. other roles, as you've seen two examples. You've seen me here on the device side and the gadgets, and I like to play with gadgets. And you've seen Boris. Let's see, gotta do that. You've seen Boris on the drug side, and there's equally fascinating research going on. And the two of those come together. And the example I just gave of monitoring brain activity during anesthesia is a perfect example of where the drug side and the device side come together to help with patient well-being. So, dig in during your residency. You'll learn a lot about all aspects of anesthesia, both on the drug and the device side. And when something catches your interest, find out more about it. You can get it from books, you can get it from people. Talk to you'll be probably at a university. I recommend university affiliated programs, usually, not exclusively, and hook up with faculty in the like. One of the things that attracted me to Arizona, last comment, is they actually offered me a joint appointment. So I was a professor of anesthesiology and aerospace engineering at the unit. What an odd title, huh? But I kind of liked it, and I still have that affiliation. So you hook up with people that have the technical background that you need to do what you want. Thanks.
Thank you.
Actually, I'll just put in. I would make one comment to Benson. I've been continually surprised after residency. I only work a day or two a week in the OR, and I still get requests for domain area expertise from industry. So there again, it's the further along you get and the deeper your knowledge of one area grows, the less you know about everything else that's going on in the world. So just like Dr. Barker said, I mean, the people that are developing, if you're going to spend all the time to develop a device, you start with an idea, but that takes you away from being in a clinical environment. And a lot of the folks involved in that really are more on the engineering side. It's amazing to me how different the language is and what people, for example, in basic science, even in engineering, think is important in clinical practice. And just having spent time in an operating room makes you really an expert that has a lot of value. And I'll just leave it at that.
And I just have to jump here and say, I have never taken an engineering course in my life, although I did marry a chemical engineer, but I have an adjunct appointment in biomedical engineering at the University of Utah. So you can get into gadgets even if you are not an engineer. So you should do that. I don't know, Dr. Barker, if you have time for one last question, which is kind of overlapping with this one, might be a little bit different, that comes from Christine.
Fire away.
Thank you so much, Dr. Barker and Dr. Heifets. I'll try to keep it short. Thank you for your presentation. And my question is, what would be the optimal career path that you would suggest based on your life experiences for someone who is interested in starting a company in medtech? Would you, for example, suggest going to academia, pursuing research, and trying to gain a professorship in multiple departments? Or would you suggest foregoing residency and starting a company from the get-go, or even perhaps entering industry, private practice, VC, and trying to spin out from there? Thank you.
The short answer is that any and all of those pathways have been done successfully. So you do what works. I'm sorry, this sounds like a cop-out, but you do the one that feels most comfortable to you. I obviously took the academic pathway, and that worked quite well for me, but because I already had the engineering background. Whether you start, I strongly recommend, even if you are going to end up working in private industry full time, a few years of academics is really good background to have under your belt, because you get a perspective not only what it's like in our specialty to do anesthesia, but what it's like to teach anesthesia. And that's a completely different challenge, learning how to, you got a patient on the table there whose life depends on what you're doing, how to get the resident to learn, but when to intervene when things are going in a direction where you're worried about the interests of the patient. And you know, when to jump in and take over the controls of the airplane, in other words, is one of the skills that you want to develop. I know people who have gotten their MDs and gone straight into industry and had very successful careers. So that's, I don't know that pathway personally, but I know there are examples where it's worked out. But most of the people I hang out with are people who started out in academic anesthesiology and then got into private industry as kind of initially a sideline. I mean, I started as a consultant less than 1 day a week with Massimo, and now I'm retired from the University of Arizona, except for the aerospace engineering, and I'm working almost full time with Massimo. Your career will evolve, and you'll find the right direction depending on your interests. It's exciting. You'll enjoy it. Do it.
Thank you very much.
Okay, so great advice, great wisdom, great presentations. Thank you so much, Dr. Heifets and Dr. Barker. Thank you to all you students for showing up and also for asking great questions. And I look forward to seeing you next week.
All right, nice meeting you, Stephen. Hope to run into you in person one day.
Great meeting. Yeah. Let's meet in person. I want to meet at that beach house you're talking from there.
Yeah, well, party in Connecticut.
Yeah, there you go.
All right. Thanks, Dr. Hop.
Bye-bye.
Thank you.
Bye.